Hey, everybody. Welcome to another Taylor Tuesday. I'm going to start out slow so we can let people jump on here as we get going. But we are very excited to have you again. So 2 weeks in a row, Ira and I get to be together, which is very exciting. But we're welcome everybody to another Taylor Tuesday. It's been an interesting time in our lives, and we have a really cool presentation, which Ira will introduce Marc Jablonski very soon. But I think you're going to find this very fascinating, very interesting, and very helpful for what you're doing for your patients right now, too. So first, just a couple little tidbits about Taylor, if you would advance, Ira, for me. If you're able. There we go. Excellent. So, we put all these on the web, and you can go back and replay this webinar if you want to get some more information, because Marc's going to have so much cool stuff that you're going to want to go back and gather. And even our old webinars that we've had, like previously, last week we had Dr. Conanello on talking about the Swift technology, and go back and you can look at all these webinars. So take a look, go to our website. You can pull this information up. You'll be able to watch. And if you don't get to take notes tonight while Marc's talking, you can actually go back and take a look at this webinar one more time. So take a visit, go to the taylormedical.com website, and you'll see the link at the top as Carla has nicely marked out there for us there. So I mention this all the time, but it's still amazing how many people don't take advantage of this. Is send in your information, take a look at the products you're using in your practice every day. Send us an Excel spreadsheet. Never say that right. An Excel spreadsheet. And send it in. Carla and the team will take a look at this. We need the list of your vendor, the items you're looking for, the SKUs if you got them, or at least the manufacturer. How much you want to get. Is it 10 rolls of something, 3 rolls, whatever, and the price that you're paying. And then if you can email that spreadsheet to admin@taylormedical.com, we can, in no time, provide an incredible analysis for you for how to save just tons of money. And I know Ira and I have talked about this a lot, as part of very big entities where we have north of 60 doctors in our groups. This has just been an absolute godsend for the savings that we have. But the point is, it can do the same thing for you, even with one doctor. And that's been proven. So please take a visit. So Ira, I will let you introduce our illustrious speaker this evening, and we can get cooking.
Thanks, Mike. I put my picture aside just so that I would not keep having to move on the screen and make everybody dizzy. Marc and I just recently met. To be very candid, what I think about Taylor is we're always looking to try and do things to help your practice. And when COVID was really getting rampant, and we were trying to get PPE supplies and trying to provide education on things that you can add to your practice, I had the opportunity to meet Marc, and we had long talks, and I wanted to figure out a way that we could provide some type of community safeness, a comfortable way to go back to work and different things. And so, we worked on looking for a solution, and it was really difficult because if you are watching what's going on, there's a lot of theft and fraud and abuse in this area since COVID has come out. And you have all these labs that are telling you that they're certified, they're not certified. I'm sure Marc's going to explain everything to you and kind of let you know what's going on. But Marc's been in the lab space for a really long time, and it's been a good partnership so far for Taylor. I can tell you that my company's been using these tests regularly. I think we've already had 2 shipments of 200 boxes that we've used already. And we're not charging anybody. We're doing it because it's just the right thing to do. And I'm going to turn it over to Marc. And Marc, I know you know how to run the PowerPoint. If you get in trouble, just tell me and I'll come back and help.
Okay, thanks so much. Appreciate it. Thanks for the intro. So, so I think rather than jump right into this, I'm going to save this for a second. There's not many slides here, but I want to kind of give everyone a high level of sort of COVID testing, the good, the bad, and the ugly, and kind of where it's come from. And so on that note, you can go back to March. This is when it all sort of came out. And there were labs that were offering serology blood test, COVID testing, where you'd send a blood sample into the lab. They send you back a result with varying degrees of success, varying degrees of accuracy. And so that sort of kind of diminished after about a month. All these time because of how crazy it's been in this COVID space. These time periods are so compressed. So along the same time, out came serology blood testing, which is rapid testing. Rapid testing is what we're going to talk about tonight. And along with that is PCR testing. PCR testing has been around for a long time. It's been used for other things as well, but very applicable, certainly for the COVID test. In the rapid testing space, you've got a lot of players out there that started without an EUA. EUA stands for Emergency Usage Authorization, and it's something that's granted by the FDA in times of pandemic. So emergency usage, and the criteria to be registered with the FDA to even offer your test to the public was simply that you had to have validated numbers and validated under the basis of your having a CLIA lab. So that was sort of the overseeing body was the fact you were CLIA. FDA didn't look at your numbers. They just said, okay, if you're doing it and you're a CLIA lab, we know that's at risk if you're wrong, so go for it. And so there were a ton of tests out there. I'm going to say somewhere around 100 different serology rapid tests. They were either IgG by themselves, IgM by themselves, or combined. Lots of names out there: Ray Bio, Famitech. I can go through the litany of them, but the important point is, over the months, we've actually used some of those tests. Some of our clinics bought them. They did well with them, but then they didn't get their authorization. They were registered but not authorized. So it became more and more apparent as you got into May and early June that if you weren't EUA authorized, that you really didn't have a test anyone was going to be able to offer their patients with confidence. And so we sourced a test that is not only EUA authorized, but has extremely good numbers. And now they've made the cut several times when more and more of these rapid tests have been delisted off the EUA list because they were never granted. There's a research only, and so it got smaller and smaller. So it went from 100 down to about 12, 13 maybe. I think it's about 9 right now. And our test is at the top of that list because it's maintained its integrity in terms of the accuracy, specificity, sensitivity, those types of things. So that's great, right? Good test. So now what? You can go test people, but what's really important is, can you report those results? Can you help bend the curve? Can you help identify who truly is and isn't a candidate for further testing? Are they IgM positive? Did they go to PCR swab? Are they IgG positive? Did they have it in the past and now they're better, they're immune? Are they a candidate for plasma, which is a whole nother discussion. But there's all these questions that come up. So with that, we realized we couldn't just say, oh, here's a cool test, go do it. And if you get a result, send it with your patient and you did your job. You really had to have a program built around this whole thing. So that's why we developed a program that I'm going to get into in a little bit here that involves CLIA oversight, the high complexity CLIA lab, and also the ability to report results compliantly per FDA requirements. And they get reported to the CDC compliantly under the high complexity CLIA oversight. So that's sort of the foundation of where we sort of started, where the industry was and where it is now. The other really interesting thing is the PCR tests that were basically used for everybody, really not meant to be a screening test. It's really for people that are symptomatic. That's evolved too. It's gone from just a straight nasopharyngeal swab, up your nasal cavity, up into your turbid. A lot of people call it a frontal lobotomy because it can be painful. Use them in a lot of drive-by settings, things like that. That's now migrated to a buccal swab, oral mucosal in your mouth, and you get the same sort of timing on the result. You send it to the lab, you get a result back 5-6 days max, usually more like 4 to 5 days. So that's where that's the latest generation of what we're doing too. So we combine this best-in-class rapid test along with best-in-class, newest, latest generation PCR testing. So just to jump into the slides real quick. So the first bullet, PCR tests may be missing as many 86% of cases. Well, the reason is that they're not really supposed to be used as a screening tool. So they're only for symptomatic patients. So what happens with all the asymptomatic patients? They've got it, but no one ever tests them with PCR because they're asymptomatic. So it's a huge gap that's been out there for a long time. One of the things about our test and any rapid test is the cost is low. It's easy to use, and you can use it repeatedly. It's one thing for your staff to take a test today, and then that's it. And so now they come back to work. They're like, okay, good. I'm negative. I don't have anything. This is great. Or IgG positive. That's good too. So what if they go out and get exposed next week? There's got to be a cadence to the testing. It can't just be one and done. Something that you've got to be able to do it on a somewhat routine basis every few weeks is good. Some people do it monthly. But the cost, the price point that we're at allows you to do that. The high specificity sensitivity really means our tests are truly indicative of the presence of COVID antibodies or the absence. So that's been the big issue along the way is, are these tests accurate? Do they really do what they're supposed to do? Well, our tests have been tested with people against people, that have actually have COVID proven. And so we know these numbers are accurate and real. And, the fourth point here is the bigger picture, right? We're really trying to get accurate numbers so that we don't have to shut the economy down every 2 weeks because something happens or school's down. Do we really have accurate numbers? Well, we really don't until everyone's tested. We don't. And so our mission is get everyone tested, and the only way to really truly do that is you have to have a screening test. And that's what this test truly is. So the Heliogen test, that's the name of our manufacturer. It's FDA emergency authorized. It's qualitative. It's not quantitative. It's a yes, no. It's not a degree of titers or anything like that. And it's the differentiation of IgM and IgG antibodies against this virus. And it's used. It's a serology test, so it's a blood drop, and it's it's very simple to use in an office setting. You might be asking, why am I talking to podiatrists? Well, I can tell you this. We have neurologists who do this test. We have gynecologists who do this test. We have integrated medical groups, chiropractors that do this test. There's really no sort of specialty that dictates whether you can or can't do this test. And furthermore, we offer the CLIA coverage, so you don't have to have a CLIA license. No clinic out there does. Nobody's got a moderate or high complexity CLIA in the clinical world. So that's why you have to have a partner that's got an association with a high complexity CLIA license. In this case, we do. So that's the actual cassette. Looks just like that. It's about the same size as that. This is the sample well. The blood goes here. The buffer or the reagent goes here. So 1 drop of blood here, 2 drops of buffer there. We're talking very small microliters here, very, very small amount of blood. We're looking at both IgG and IgM isotopes reported separately. So you've got the ability to see. I'll go through that in a second, but you'll see how it works. Storage, they're not to be frozen. They're to be kept basically at room temperature, and they'll last for 2 years. So here are the numbers. Sensitivity, true positives, right? That's the number if we say it's positive, how certain are we that it's true? So with the IgG, well, the IgM is 100%. IgG is 96.7%, and they say combined they round it to 100%. Specificity, true negatives, right? If I say it's not, if you don't have coronavirus, how accurate is that call? So on IgM, 100%, IgG 97.5 combined, they give it a 97.5. This is what the FDA has written their EUA authorization on based on these numbers. So many of you probably have heard these acronyms, IgG, IgM, and these antibodies. You probably know what they are. You're all doctors. But just for the sake of review, IgG is the antibody that forms for people that have had the virus in the past and gotten over it. And now they've got that protective antibody that conventional medical wisdom will say makes you immune. IgM is the antibody that says you have either recent or acute virus. So it's really an indication of, do you actually have something going on right now? Is it an active virus? And there's an interesting curve. It kind of looks like that, where when the IgM really spikes, in about 20 days, it drops off, right? So it starts with IgM, and it's kind of a flimsy molecule, and it spikes and drops off in about 20 days. And about 15 days in, the IgG starts to pick up. So they cross. In this middle period is a time when you can actually be both IgG and IgM positive. But the timing is typically, you could be IgG or IgM positive with the active virus for about 20 days, and then it starts converting to the IgG, and that can go out for quite a while. So we're looking at both of those things. But just in terms of the, sort of the bullet points of the program itself, simple, easy to administer. You've got an easy to read visual result. Obviously very portable. There's no specialized lab equipment needed. It's fast. You're going to get results in 10 minutes. And we do distinguish between active and recovered infections. That's the really, I think, one of the most powerful things about this test is you get both reads. And it's accurate. We've got the leading sensitivity and specificity numbers out there, virtually no false positives. And again, scalability often equates to price. And so the price is at a point where you can offer this to your patients. You can offer this to your staff. And really what we're trying to do with this, there are some practices that look at it as somewhat of a revenue stream, fine. But I think Dr. Krause's and Dr. King's thought on this is that, this is really meant to be, let's give the staff and the patients peace of mind to know and feel comfortable that they can come to your practice, come back and get procedures done and do the things you guys normally do without the fear of sitting next to someone that's infected or having a staff member interact with them that's potentially infected. So if you've got this protocol in place, it's not the end all, but it certainly takes you up a notch in a big way for both your staff and your patients to feeling comfortable being in your practice. And ultimately, that's what it's all about. So, here it is. We got a drop of blood, and it's going to be put on this little sample well. I'm going to put the buffer on this well here, and in 10 minutes, you're going to get a read. And I'll show you how the reads, the various reads you can get will look like in just a second here. So these are manufactured in an ISO 13485 certified facility. Doesn't mean much to you, but it's really no higher degree of accreditation in manufacturing. Again, validated against real COVID-19 patients that actually had virus. 10-minute results, simple, straightforward. EUA was a 92-page abstract submitted, the methodology and technology. This is not taken lightly. It's really, really tough to get an authorization by FDA. In fact, many didn't. And then it was granted on the 29th of May. And we have the CLIA umbrella in place for compliance. So why is that? What's the importance of that? If you look at any of the literature that surrounds this and other tests, it'll tell you intended for use under a moderate or high complexity CLIA license. Well, the only entities that have those types of licenses are laboratories. Nobody goes to a laboratory, in some office park somewhere to go get a test like this. It's all done at the clinic level. So the only way to be compliant with that is to partner with a CLIA, high complexity CLIA lab in our case. And then by onboarding with that CLIA lab, basically becoming their customer, there's no financial transaction or no responsibility there. But now you've got the ability, like any test, if you were to run any test out remotely from a lab that requires a high complexity CLIA, you have to onboard with a lab to be able to do that because that's got to be sent somewhere. You don't send this kit into the lab to be reviewed. You do send the results. So we provide you with a resulting mechanism or reporting mechanism where you're going to be able to, throughout the week as you test people, it'll ask for the initials, date of birth, and then was it positive for IgG, IgM, or both, or clear. You just indicate that. And over the course of a week, you'll fill that thing up. And at the end of the week, you submit it. There's a secure, HIPAA secure encrypted link that you upload it to. And then now it goes to the lab. They review those results. And then they're going to then package them with other clinics that send results in as well. And that all goes to the CDC under their high complexity CLIA license. That's how it's got to be done. The days of just testing people and calling up the health department and saying, hey, I got a positive. It was like that. It was the Wild West, and those days are gone. So this is as tight of a program, and that's the only reason Dr. Krause would have brought me, because I know how you guys are, and they know how I am, and we're both cut from the same cloth. We're very compliance specific and anal about this stuff, and so you don't want to touch any type of COVID testing that doesn't have those elements to it. Super important. And again, peace of mind, safety for the staff and patients. And let me jump to this next slide here. This is the actual. So we got a drop of blood. It goes on the sample well, goes here, and the buffer goes here. And then what's going to happen is you're going to end up with results that look like this. So this is a result. This is the M line. This is the G line. It's kind of tough to see. It's a little blurry, but this means IgM positive. This means IgG positive, and this is clear. So on the IgM, you see a red line on the IgM and a red line on clear. Boom, that's an IgM positive patient. Now, if that doesn't happen and the line forms at the IgG line and the clear line, that's a positive IgG patient. Then, as I was speaking about, in that little small period of time where they might be both, you can have a result that shows you that they're both. And then you can have clear. I will tell you, probably statistically, depending on where you are in the country, anywhere from 95, I'd say 92 to 95% are going to be clear. And then you're going to get a lot of these, which is the IgG. I don't know if you can see my mouse moving around, but I'm pointing at the IgG one. You'll get the IgG positive, and then you'll get a very small percentage of IgM positives. So what do you do? IgM positive. Well, here's what we do to give you a plan. And when you onboard with our CLIA, our high complexity CLIA lab, they're also going to send you free of charge the oral mucosal swabs I was talking about earlier. And so you'll have those on hand. So the protocol is IgM positive. Now that's as good as symptomatic. That person needs to be swabbed. Whether you want to send them to an ER or a urgent care or a hospital, whatever, you can do that. That's fine. Or you can swab them right there, package it up, send it in. So you're not sending the patient somewhere else. Send it into the lab, and they'll get your result back in a secure portal within about 5 days. And so that result then goes on your sheet as well and submitted once you've got those results back. So it's a really nice 360 program that we're giving you, where you've got not only the rapid test, which is a screening component, but then you've got the other side, which is the PCR testing in the most up-to-date form, which is the mucosal or mucosal swab. Let me see what we got in this next slide here. So this one's a little bit confusing. This one's a little bit more accurate. This is right out of the NIH serology test evaluation, and this is again showing you the numbers on the sensitivity and specificity. There's here you've got IgM sensitivity 30 out of 30, IgM specificity 30 out of 30 or 80 out of 80, sensitivity 29 out of 30. These are just phenomenal numbers, and that's why we decided to go with this company, frankly, and it really made the most sense. Well, that's really it. I don't know if that was too quick, if I burned up too much material too quickly, but Ira, if you want to talk about how you're using it in your clinic and your experience with it, I'm happy to elaborate on any one or all of those points.
Sure, Mark. And we actually have a few questions. I think that, again, the beauty about it is that we tried to do something that was compliant, and just so you all know, the CPT passed emergency codes that are out there for COVID testing. I don't know if we haven't submitted any. I can tell you that our company is doing them more, again, as Mark said, as more of trying to do the right thing. We do frequent tests. We have the tests available. Our staff know that they can call and find out. The only thing that I would say that Mark, what we're doing is and we haven't had any, but if we had anybody that came back positive and had to do a nasal swab, we would probably send them home to quarantine until we found out what the nasal swab is, just to be a little bit more on the safe side.
That's protocol. Yeah, IgM positive is indicated.
Right. So I think that you all have to have a protocol that you're going to use in the office. And again, part of, I think, what the beauty about Talar is, and Mark doesn't have to say it too bad, but I did beat him up to make sure he got the price at a great price. So it's definitely something that we wanted to be something that you would use on a regular basis in your practice. And we've been using it really, really well. So I'm going to take the first question, Mike. There happen to be two of the same one. People are asking if there's a finger stick or a venipuncture. You can do this with a finger stick. They actually give you a very nice finger stick where you press the button down. It's almost painless to do it. It is painless, to be very candid with you. And you get the blood. It comes. It's really pretty cool. It's an alcohol swab, a Band-Aid, a finger stick, a cassette, and the reagent. I mean, it's really the longest part is waiting 10 minutes. It really is very simple and very easy to do. Mike?
So interesting, Mark, is that one of the questions here, and I think it's very pertinent, something that I wanted to ask is, so why are places like CVS and these minute clinics doing the frontal lobotomy version of these tests as opposed to doing something that seems to be, really accurate and easy and rapid?
And taking so long to get back.
Yeah,
Right.
good questions. Good questions. So we actually spoke with Albertsons. We spoke with the director of their laboratory, and their criteria is simply it's got to be CLIA waived, and they wanted, I think that was their main criteria, so that it could be done. We have many pharmacies that operate under the CLIA umbrella that we offer through our high complexity lab. Large, highly visible groups like that, they're super. They lay down the criteria. CVS probably the same way. They're looking at rapid testing right now at CVS. That's one of the ones that's actually looking at it very seriously. And the PCR test. I think what's the point that gets missed with all these big groups is that you don't screen with a PCR test, nor do you end up with great numbers of the PCR test because you're not really accurately seeing the population. You're not seeing what's going on in the population. You're saying, oh, you're symptomatic, come in. I don't think many people go just to get swabbed just for fun, unless they're symptomatic. So it's kind of a disconnect with some groups, like big groups like CVS. It's just they're kind of in their lane and in their box. They do what they do. But as I said, in the pharmacy world, we've got many pharmacies, chains of 6, 8, 10 pharmacies in a city that use our test extensively. I like it a lot.
So I'll share a real world story. Many people don't know, but I actually tested positive for COVID. I was getting ready to have a epidural in my shoulder April 24th. No symptoms, nothing wrong. It was at the height of all the craziness. And in Atlanta, there was a place that was offering 30-minute nasal swabs. So I thought I would get an instantaneous result. Well, the day I decided to go was the day they canceled it because they said those 30-minute tests were inaccurate. So I went on my own, got a nasal swab, and went and had my procedure the next day, had my temperature done, had no symptoms. Everything was fine. The hospital, this is a big hospital system in Atlanta, got a hold of me 9 days after I had my nasal swab, and they say, oh, you're positive. I said, oh, what should I do? They said, well, you should have been quarantining yourself since you took the test. And I said, why would I quarantine myself since I took the test? Because I have no symptoms. I just took it for the heck of it. And how do you know I wasn't getting a positive reading on day 13 or day 1? It happened to be, and Mark knows this story well, the day we had ordered our tests, and we had ordered them to come overnight to my company. And they didn't arrive on time. So we actually found another one of his clients, and I had to track them down and get it. But I took the test, and I turned out to be negative, and I had no IgG, IgM. I still may get IgM later on. I presume, Mark, I could get antibodies, right?
Maybe IgG. Yeah, IgG.
Yeah, IgG. But anyway, we do this. We do it at our company. I've done it once a month. I just do it as just a safety protocol and make sure everything's okay. And I do want to let everybody know that this is not available on the portal, but it is through a link that's related to Mark's company. I know that he didn't have it on the slide, so we can make it available for anybody that wants to get the link and order this. But yeah, I just want to tell you it was a real life story. I'm using it. And Mike, I'm sure you guys have developed a protocol because you guys are implementing this as well.
Yeah, we have. And so we're just getting started with this. And so, and, one of the things that's interesting, Ira, is, a lot of people have been doing a lot of traveling and they've cut that back, but people want to start to get traveling again. So a question I guess I have on that same regard, Mark, is there are many states that, for example, if I go to Atlanta and I travel back to the Northeast, they say you have to quarantine for 14 days or have a negative test. Do you expect that they would accept this as a negative test if it was a across the board negative?
I've been asked the question before, and the answer is it's airport specific. It's one of those things that's in a state, and they have certain criteria. I haven't actually explored too deeply in terms of which airports, how they do it in which states, what they'll accept, if they'll accept this or PCR. The funny thing about PCR is, not funny, but ironic, is that you've got a 30% plus false negative rate. So they're telling you don't have it when you really do. And I look at our tests, and our specificity is the true negatives, right? And our specificity is like 100%. So to me,
by the time you get back the PCR test, you've already finished your quarantine.
Right.
And Mark, I think, and maybe I'm going to take it a step further on what Mike asked. I think that some of these states have a quarantine process. It's not necessarily an airport thing. Like, I can give you an example. My brother is a professor at the University of Pennsylvania, and they told him that if he leaves to go on vacation and leaves Pennsylvania, he has to quarantine himself for 14 days or take a test. I think what Mike is asking, does this test satisfy any of these state requirements that say if you come and travel to our borders and come to our state, not necessarily through an airport, that this is a viable test for us to document that we are not infected?
And I don't have a firm answer for you. And
okay.
On one hand, on the other hand, I would say it's EUA authorized, so it's a test that has passed the muster, and so it's recognized by the FDA. And so I don't know if they say it's not, okay, why? So that's something worth.
That's a fair
research on.
That's a fair answer. I mean, I know it's the state variable kind of thing, but another real life thing is I just came back from Tennessee, so I have to be quarantined for 14 days or have a negative test. Well, I can't get the test for a week, and I don't get the results back for another week, so I might as well just quarantine anyway. So,
right, yeah,
but if I can do this test, I'm willing to say, hey, here's my result. It's proven. Sure. It's a documented, highly certified laboratory, and there you go.
Yeah, I mean,
and I'm assuming, Mark, if we get any new updates from you, that we'll be able to share this with our members. So if this is something that becomes recognized or acknowledged as something that people can say, hey, I've done this, particularly, again, people who are at jobs who aren't going away now because their jobs have mandated either quarantine or testing.
Yeah, agreed. That's good. I'll do some research on it. That's really worth doing. I want to find that out myself. One comment to one of the questions there about the serology or venipuncture or finger stick. So venipuncture is so it's in the literature that it's supposed to be done venipuncture, and if you look at it, the reason they did that was the only blood they had when they did this clinical testing was in a laboratory that was basically blood that was drawn. It was in test tubes. So that said, that was the EUA based on that. However, the decision is up to the provider. How you get a drop of blood is up to you. So if you get a drop of blood, venipuncture, if you get a drop of blood, that's a provider's call. That's just what was done because that's all they had. They had tubes of blood, not doing finger stick. There's no difference in the blood. Blood's blood. So that's kind of the answer to that question.
Mark, we've got a couple of questions, and I'm curious. I know you and I talked about this early on, and I know that I've decided not to do it. Do you have any clients that are using any of the emergency CPT codes that were developed for COVID testing and submitting the test for reimbursement? Have you seen anybody doing that, and do you have any experience? I'm just curious.
So I get the question, I don't know, every couple of days. A lot of it comes from pharmacy because they work in the NDC coding world. We have documents that are supplied by our lab partner that says, here are all the codes. What we don't do, and compliance-wise are not allowed to do, is coach, clinics on how to do this. So we're saying here, you're a coding expert, so I could provide this stuff to you. I think you might have seen it already, and it's got all the codes in there. And, so that's about as far as we go with it. Yes, you can. I know some are, but it's not the norm. Most, if they're doing this, it's cash or like you're doing, absorbed by the practice. Some will charge a little premium if they do it cash for patients or certainly not staff, but for patients. But yeah, I don't see very much insurance reimbursement on it on that test.
Could you talk a little bit, Mark, about the finger stick process? I know Ira described it. It's very simple, but some people are very skittish about doing things like that, and just about how simple this is and truly painless. Yeah.
So when you do a finger stick, it's typically on the inside of the finger. It's not on the pad right here. You want to do it just off to the side. And it's where the capillaries are. And it's a little plastic device that you twist the top off and you place it against the finger. And as you push it, it's a spring-loaded little tiny blade. It goes in there. It's a 31 gauge blade. It's really small. It's like a 31 gauge needle. And you pull it away and the drop slowly forms. And before you do that, you want to warm the hands, probably wash them in warm water, kind of get the blood flow going down the hand, like, milk it down. And then, all it takes is one drop. It doesn't take very much. And then there's a pipette that comes with the kit, and you pipette that little bit of blood off right onto the kit, right onto the sample well. And then you put 2 drops of buffer in the reagent well, and then you'll see within 10, you set a timer for 10 minutes. I mean, typically this is done by MAs or techs or something like that. I mean, I've been at trade shows and done 20 of them myself.
So one thing I did notice is that we've got a 5-minute window. Basically, you wait 10 minutes for the test to come back. Mm-hmm. After 15, the results are considered potentially invalid.
Yeah, you don't want to go.
So what happens if they look at it at, say, 17 minutes? Is it always going to be positive, always negative, or just not valid? Period.
Yeah, I mean, the rules of the road are, 10 minutes, that's your call. And so whatever you see in 10 minutes in, that's it. I have one sitting in my drawer that I've done, and it's been there for weeks, and it's the same thing, so nothing's changed. That said, though, we just like to stick with the dogma of 10 minutes, that's your call.
No, of course, that's great.
The interesting thing, Mike, is if you have done it as it's going on, what you'll actually see is the reagent kind of creeps up, and the whole testing strip just gets saturated with the reagent. So you can tell that it's been sitting for a longer period of time. Right. So it's definitely a thing. So I can tell you there were 3 things when Mark and I were talking to get this set up that we had to get, and he delivered on everything. I wanted to make sure that we were covered under clear so that nobody would have any problems providing this in their offices. I wanted him to make sure that he gave us a good price, and he did. And the last thing was, when I got my original kit, we had these god-awful finger sticks, and I said, Mark, we got to get better finger sticks. You better get everybody some really good spring-loaded finger sticks. He made sure that he got the right thing for everybody. So I think it's been a win-win situation. I think those practices that have been using it have been very, very pleased. And I think what I will tell everybody here is that we reserve an hour for time, and if we don't have an hour, it is what it is. I will tell you that Mike and I are always available to answer any questions that are not necessarily always related to the topic, but since we do know, we actually we have an APMA phone call on billing and coding right after we get off of this one. For those of you who are having a 59 modifier issue, we're working on it. But if there are no other questions, I really just want to take the time to thank everybody who has come out. I look at the guest list and the attendees every week, and we've got regular people who have followed us and have been part of what I would say the Talar family. We've tried to provide good information for you, your practices, and your patients and your staff. We are getting ready to launch Talar University. We're going to be talking about clinical protocols and helping you figure out what's the best things that you can do. It's not just about buying things at the best price. I think that we're trying to be a podiatric family, and we want to give back to the profession. We're an organization that was developed by podiatrists for podiatrists. Next weekend, we're going to be having David Zuckerman. He has been at the forefront of introducing laser therapy and alternative treatment plans to practices. So we're looking forward to having him on September 1st. Mike, do you have any closing comments before we say goodbye to everybody?
No, just a thank you to Mark. It's very fascinating science. I think it's really cool.
Hmm.
I think that, as you alluded to earlier in it's becoming such a cottage industry that, we want to be careful as providers to use things that have the highest certifications, the highest reliability. And, so I think that's what I'm proud of as a board member of Talar, is that we're bringing that through your company. So thank you, Mark. It's very
Yeah.
appreciated for what you're doing here.
Thank you. Appreciate that. Yeah, and again, I echo with what both gentlemen have said. Thanks for attending and listening. Siobhan did want me to tell you that if you are interested in ordering these, you can go to the COVID-19 Resource Center of the Talar Medical website, and then you can select COVID-19 antibody rapid test and scroll down to the bottom where it says order now, and there's a easy order form there. So.
And there's a link in the chat box. If you're still hanging on here, guys, you can click in the chat box, open up a link. It'll take you right over so you can order it before Mark's even got his computer turned off.
Anyway, thank you again. We look forward to seeing you in 2 weeks. Mark, I'm sure I'll speak to you. Thanks for coming on. And if you get that information on that question that Dr. King brought up, we'll share it with our members when you find out.
You got it. Yeah, I appreciate that. Thanks, guys. Appreciate it.
Great. Have
Thank
a
you,
wonderful
everybody.
night.
Everyone.
Bye.
Everybody have a great night.
Bye-bye.